So hi, I'm Gary Ansel, and I'm here with Dr. Ash, who presented the clinical late-breaking trials on women and aneurysm repair. So we'll start there, and then we'll move on to just VIVA in general. So thanks again for presenting the late-breaking trial data. We're really happy because VIVA appears to be one of the bright spots to be, really releasing your late-breaking trial. Tell me a little bit about your studies for the audience again.
Sure. So the LUCY trial was essentially designed to look at women versus men, specifically treating aneurysmal disease with the Ovation device in a prospective fashion. The thought being that we could do a head-to-head and maybe more accurately reflect that percentage of women who present with aneurysms versus men in real life, which typically hasn't been represented in some of the more historic studies.
And that's an important point, because oftentimes we forget that we're only as good as our data, and women are really underrepresented in trials, correct?
Correct. I mean, historically, even in some of the older trials when it comes to coronary disease, they've been underrepresented. And so we've seen that. There have been some advances, of course, but not only are they underrepresented, but what we find is when we really tease out the data, they present differently, and often they mature their disease process differently, not only in aneurysmal disease, but in other spaces as well.
And I found that, yes, thank you. That was a great answer. But it's really funny because sometimes we can make the wrong clinical decision in policy making, because if you look at some of the screening for AAAs, they'll say, well, women don't benefit from it. But as you notice, they have a higher rupture rate at a smaller size.
They do.
And so that just is a total policy misconnect. And it's because they're underrepresented in the original trial data.
Correct. I mean, and I think, one of the issues with some of the original trials is if you look at the open data or even the older data of the original studies, you're looking at graphs that maybe were a little bit more clunky, so to speak. They're big French sizes, they're stiff. Some of those trials were done long before hydrophilic coating came out. And so I'm not sure that it's fair really to the female population to take that data and then extrapolate it and say somehow women are not suited for this treatment option. I mean, we've come such a long way, just even in the last 5 to 10 years in terms of the device availability. And so I do think we need to look at that a little bit more closely.
And I thought it's a great point. I think even another point that you had about, really maybe we should be re-looking at how we treat women differently. We found it in coronary disease. Mm-hmm. But aneurysms is another way that, again, you were noting the increased rupture rate at a smaller size for the female population.
Right.
Trying to get this cookbook guidelines for everybody is probably not the smartest move for policy.
Right. And I think when you reach those upper limits of diameter in the female population, that's when you start to lose your endovascular window, because you're dealing with a smaller vessel to begin with. And at least anecdotally, I think that women have that occlusive disease component that complicates things so significantly. I know I've treated women who've presented with a rupture at 3.9, and that's frightening. And it's particularly frightening when their iliacs are nearly occluded in the middle of that rupture. And so the question is, really when should we be treating? And maybe instead of just a diameter, maybe we should be looking at ratios. And maybe that's where we need to be headed now, particularly given that so many of these can be done percutaneously with such low risk.
Right. And I totally, my own practice without even data to support that, we look not only at size, but we look at the anatomy to say, so am I going to have to use a really unproven technique of, putting in either, not fenestrated is approved, but not usually very well for a small woman,
sure, yeah.
But putting in chimneys and snorkels and things like that we really don't have great data for, just to wait for another 0.2 of growth. It just never seemed to make sense to me, especially like you said, these are almost outpatient procedures. I mean, they're percutaneous, these patients do extremely well, the risk of complications is extremely low. Right. It's kind of like, what's the downside other than financially we're treating more patients, but I think hopefully at a better outcome.
Right.
So you've been at VIVA, it's for the actually the end of the second day almost.
Right.
So have you been here before?
Yes.
Okay.
Yeah.
So what changed this year? Did you like? What didn't you like? What do you think?
I like some of the breakouts. They've been a lot of fun. I think that's been interesting to have just smaller groups you know, and events like this, I think that's been a nice improvement. So I think that's been a positive thing for sure.
That's great. We try to change it every year, and you know, the main arena has its role, but these intimate areas, you know, and trying to get, you know, stuff where even with glass around it so people can watch the debates going on, and doing more spontaneous conversation, because I think it's really important. So you're a vascular surgeon, correct?
Correct.
Okay. I'm a cardiologist. We have radiologists here. We have vascular medicine here. Well, do you like the integrated approach that VIVA has, or you don't like the approach that VIVA has?
I like it. I think it brings a lot to the table. I mean, let's face it, you know, we all are providing this, you know, comprehensive care to these patients, and we have a lot to learn from each other. You know, we all have our strengths and weaknesses, and I think, you know, to some degree, VIVA does a great job of bringing some specialties together that are, you know, traditionally sometimes a little debatable, but I think that we all have a lot to learn from each other, and I think it's a huge benefit to have that option here to kind of conduct yourselves with colleagues that may do things differently, you know, and it's a great experience.
Well, we're glad you're here, because the other thing that we haven't been as integrated about is we've been very underrepresented of having female physicians here. And we note that as the board, and we've made a concerted effort to try to change that because of people like yourself that bring such a high level of expertise. We appreciate you giving us some time today, and have everybody continue to join VIVA 17. Thank you.
Thank you.